Good evening. We're going to start. We have a real pleasure tonight. We are going to discuss what is very important, which is really fainting, syncope. Syncope means fainting. It doesn't mean no sin. And collapse, and how to stay on your feet. A real problem. We just recently have begun to understand, in the last few years, begun to understand how important falls are to seniors and how we have to do our best to avoid them, what to do if they happen, and the neurologic aspects of them. To do this all, we have Dr. Gary Bernardini, who is the chairman of the neurology department at NYPQ. He is actually the first chairman of neurology. Neurology had been part of medicine before this, and we're honored to have him. Neurology, for those of you who don't know, actually is the forefront of internal medicine these days. I keep on telling that to my students. I have a kid now who's going to neurology. And in reality, we know less about the brain than any other part of the body. We have to find out more about the brain. If you have any questions, please write them down and hand them to me, and I'll ask them later on for you. Thanks a lot, Dr. Bernardini.
Thank you. Now, I appreciate the invitation to come speak to you, and I've got to have my position right here, I guess.
Yeah, for the selfie.
Yeah, right. Thank you very much. I have been here since January of last year, and I trained in Cornell. I did a neurology residency. I did a fellowship in Columbia in neurocritical care and stroke, and then I went to Albany for about 14 years and worked there, and now I came back. So thank you very much for inviting me. I'm going to talk about a difficult subject, the dizziness and collapse and syncope. This is, I'd say as a neurologist, this is up to a third of the referrals that we see. Both patients coming into the hospital and through the emergency room, and patients coming to see me in clinic. I had 6 patients in clinic this afternoon, and one came to see me because of vertigo, spinning. Very common symptom. I'm going to define this word syncope. So syncope means actually passing out. You pass out. You're walking along, you're in your kitchen, you're outside, you're working, you're doing something, and you pass out. A lot of times there's no warning. Hopefully you're close to someone who catches you and you don't hit your head, which could cause further problems. But syncope is literally passing out. You lose all tone of your body. And most people, they pass out. They're down on the ground for a few minutes. Sometimes there's a little bit of shaking when they're on the ground, which is sometimes misperceived as a patient having a seizure. But if you pass out, almost everybody shakes a little bit, then you wake up. And a lot of people wake up, they're fully awake. What happened? What happened? Oh, you passed out. And in some cases, it's at home. In some cases, it's alone. You know, someone is alone. Not such a great scenario. But for syncope, this is what happens. And for a true passing out episode, usually there's not a confusion afterwards. You kind of wake up, you go, oh, what happened? Where am I? You kind of know who you are and what you were doing, you know, the 2 minutes before you passed out. So that's the definition. About 6% of hospital admissions are due to syncope, and it's about 3% of all emergency room visits. And you can see experience, I have a pointer, but...
You do.
What's that?
You do.
I do. Is that it?
Should be there.
It's experienced by a lot of young people, less than
Press
40.
on top, maybe it's there. It's there somewhere, one of them.
Let's see, I'll just play with it a little bit, see if I can find it. Is it one of these?
There it is.
Oh, I see. Okay. Great. So it's fairly common in people less than 40, but there's 6% annual incidence of those over 75 years old. But honestly, in my experience as a neurologist, we see all ages. We see the young, we see what's called middle age and elderly people, and you can put an age on that as you see fit. Now, the causes, most of the causes of passing out are benign. And when I say that, usually someone should get worked up if you pass out. So it doesn't mean if you pass out and you're at home and you wake up and your family member finds you that it's okay. You definitely should see a doctor because there are some more serious causes, and those are the ones that are caused by the heart. So you can go into what's called an arrhythmia. Your heart beats at a very steady pace, but sometimes the heartbeat changes. It can go very fast or become very irregular. And the whole reason that you pass out is you don't get blood to the brain. So suddenly the heart's not pumping like it should. or your blood pressure is dropping. And I'm going to show you some cases because I think it kind of makes sense. And you're not getting the proper blood to your brain and you pass out. You end up on the ground, suddenly you're getting blood back to your brain and you wake back up. In the initial assessment, about 50% of the patients that have this passing out episode, we don't know the cause. And it deserves a workup, and we're going to talk about that in the next 30 minutes or so. It's different than dizziness. So dizziness is even more common. I feel woozy. I feel lightheaded. Every time I get up, I feel lightheaded. And a very common scenario of patients that we see as neurologists and internists, feeling unbalanced, lightheaded. Vertigo is different. Vertigo is spinning of the room. And sometimes someone who's never had this experience will come in, and suddenly they wake up in the morning and things are spinning around. You can't stand up, everything's moving, you get sick to your stomach, you come into the emergency room, and that's vertigo. It's a little bit different than our definition of disequilibrium, which just means you feel unsteady. And that could be due to some things such as stroke or something else. But we're going to get into that and talk more about that. But I think dizziness, I like to divide up, again, into two different things. One is lightheadedness. You get lightheaded when you stand up, or you feel lightheaded. You constantly feel kind of like you're about to pass out, but you don't. And then there's true vertigo when things are spinning around. We'll talk about the causes. Dizziness is common, and usually the underlying cause is benign. Unfortunately, as we all age, the mechanism that helps you when you stand up quickly, and this can happen to anybody, occasionally you'll kind of get spots in your eyes a little bit, and you feel kind of a little lightheaded for a second or two, then you're okay. As we age, that mechanism that gets the blood back up to the brain when you stand up is not as good. So a lot of times as people get older, when you stand up, blood tends to pool in the legs and it doesn't get up to the brain, and sometimes you can feel that lightheadedness for several minutes after standing up, then suddenly the blood gets back up to the brain and you're doing okay. So a lot of the causes of dizziness are what we term benign. But there are specific causes. One would be a drop in blood pressure when you stand up, which I just mentioned, which is orthostasis. Very common. Very common as you get into your 60s, 70s, 80s, and beyond. When you stand up, blood pools a little bit, there's a dizziness, and guess what the treatment is? Get up slowly. Sorry, no pill to take for that one. But that can be very beneficial. You get up slowly, allows the body to adjust, and the blood doesn't drop in. Blood pressure doesn't drop, and you're okay. Sometimes there's a drop in blood sugar. Sometimes someone's dehydrated, they haven't been drinking, it's hot. I come from Texas, that's really hot. And I know when it gets hot here, people complain it's 80 degrees. And to me, that's a nice spring day. But it can get hot still during the summer. You don't drink, you're dehydrated, you can get dizzy. The severe extent of that is you could pass out from dehydration. So again, that comes back to syncope. Sometimes medications, you can be started on a new blood pressure medication or some other medication that drops your blood pressure that could lead to dizziness. And then when we get to vertigo, I usually tell my patients there's three causes, and I have two up here. One cause is a stroke, but that's much rarer than the other two causes. The other two causes of vertigo, again, spinning of the room. It can either go counterclockwise or clockwise, end over end. There's all kinds of variations of this theme. One is an inner ear problem, One is an inner ear problem that is a positional problem. Some of my patients get in a certain position, they're at night, they roll off to the right, suddenly things start spinning. This is called benign positional vertigo. And that's due to an inner ear problem. And it's a benign process, but it can be very disabling. So one of the techniques, and I actually tell my patients that are tech savvy, that can use a computer, is go online, and there's a procedure which I haven't put up here called the Epley maneuver, which is actually a maneuver to try to desensitize the brain so that you don't get the spinning. So that's vertigo. The other cause of vertigo is an infection. So you can have a viral infection or have been around someone who was sick, you didn't know it, the viral infection goes to the inner ear and the spinning goes on. And usually with the infection, the true vertigo can last up to a week or 10 days. So it's pretty bad in the beginning, it's get better, but it takes about a week to get over if you have an infection in the inner ear. Both of these, though, are benign benign causes. There's not, it's not dangerous to have it. It can be disabling, particularly if you get vertigo and you're spinning. You may not be able to stand up. You may feel sick. You may come into the hospital and have to sit in the bed, be in the bed for the first couple of days, not moving, because every time you move, things start spinning. But most people recover from that, and there's really nothing serious going on. So what do we do when again, we're going to get back to syncope, the passing out. What do? We get a history. We got a history and physical exam. How was the patient before they came in and they had the passing out? Were they feeling sick? Did they have a viral syndrome? Were they put on new medication? Did they start new blood pressure medication that dropped that blood pressure? And they come in. We do a 12-lead EKG, and that's a heart monitor to see if the heart is beating correctly. Is it in a normal rhythm? Or is it in an accelerated rhythm? Is it going fast? Or is it in another rhythm called atrial fibrillation, which sometimes can keep the heart from pumping like it's supposed to, and people can pass out. Very detailed account of the event, and I know that Mel will agree with me that actually the old teaching, if you're in medical school, is that history is everything. So talking to the patient is everything. It's a lost art, but it's everything. So sitting and talking to patients, hearing the story will tell you what the problem is. And when I tell my residents this, it's like, well, let's get the MRI scan. Yeah, but the MRI scan's not going to give us the answer in some of the cases. So learning about what the causes were, what happened before the event, the activity before the event, the position the patient was at the time of the event can be very important. And then the questions of, was the loss of consciousness complete? If this is witnessed, their family members, or you're in a busy corner of a street and you pass out, and the people there that happen to look at you before you pass out. It's very important to get eyewitness of what happened. Was that loss of consciousness rapid and short duration? Most of the benign syncope, you pass out, you wake up within a minute. You're fully awake and ready to go. It's only if that's prolonged and you don't wake up for 5 or 10 minutes, then the neurologist gets involved, because then we think that may be a seizure. And we'll get at almost the last slide I have to show you, seizure is a very rare cause of syncope. So seizure, neurologists always call for syncope, passing out episode, but we rarely have much to say because it's usually not a seizure. The red flags, however, if we get a history and we find that someone had chest pain before it happened, or they were short of breath, or they had back pain, or they felt like the heart was racing, or they had a headache, or there was focal neurological findings, or they complained of vision changes, or unsteadiness of slurred speech. A lot of these are concerns for a stroke as a cause of that passing out episode. Certainly with exertional chest pain and shortness of breath, any kind of chest pain, we think about a heart problem. Are you having a heart attack? Heart attack, you have a heart attack, you lose the pumping mechanism of the heart, blood doesn't get up to the brain, and you can actually pass out from that. Other things, the other things listed here is you can have dissections of main vessels, which is a tear in the main vessel, which leads, again, not to getting blood where it's supposed to go, and you can pass out. When do we admit patients to the hospital? Usually when they have a history of heart problems. This is congestive heart failure, ventricular arrhythmias, or what's called acute coronary syndrome, so you're having a heart attack. Any evidence of congestive heart failure, water on the lungs is one of the terms, congestive heart failure, or valvular heart disease, or you come in the emergency room and there's found an abnormal ECG, electrocardiogram, you're going to get admitted to the hospital for a full workup. And then consideration, if you're older than 60, or you have a history of some heart disease, or a family history of people with sudden death, or exertional syncope, that is, when you're active, for some reason, you pass out. And then that deserves an admission, considered admission to the hospital. Now, we're going to talk about, I'm going to show you a laundry list of things that cause syncope. We're going to talk about cardiac or heart-related causes, and we're going to talk about non-cardiac causes, which is where a neurologist such as myself would be involved. So I'm going to give you a bunch of terms, and I apologize, but vasodepressor, or vasovagal, or neurocardiogenic syncope, the most common cause of syncope. What is that? What is that fancy term, vasovagal? Well, what happens is there's a stress to the system. Some people may not have eaten, or they're stressed out, or they're hot, or they're tired, or something is going on. And the vagus nerve, which goes to the heart, that vagus nerve, when that nerve is stimulated, the heart slows down. So when someone comes in and it's a vasovagal problem, that nerve is overstimulated, the heart slows down, doesn't pump blood to the brain, and you pass out. Now, it's really what I call a diagnosis of exclusion. So after your full workup, and you've got the history, and you've ruled out that the person had a heart problem, usually it's called vasovagal syncope, and we'll talk about some of the treatment later. Another is situational. Going to the bathroom sometimes will cause you to pass out. Some are psychogenic, not really physiologic. Orthostatic is someone who has really major blood pressure drop when they stand up. You're sitting, you're fine. You stand up, that blood pressure drops. And again, this is a common theme that can lead to syncope. Drug-induced blood pressure medications. What's called carotid sinus sensitivity. This is extremely rare. I put it on the list just to put it on the list. I have never seen this. A seizure, very rare. Neurologists are called. Like I said, patient passes out, they come into the hospital, the cardiologist and neurologist will be called. We'll come, we'll say, looks good, probably vasovagal, probably not seizure. The history doesn't fit it, and it's really based on history. And when a neurologist gets serious and think, I think this is actually seizure, will be a patient who passes out, stays unconscious for about 5 or 10 minutes, bites their tongue, there's clearly shaking activity, and they may lose control of their bladder or bowel function. And then suddenly our attention gets perked up, and I say, I think that's probably a seizure. We'll get an EEG, which is an electroencephalogram, and that may support a seizure or not. But again, it's kind of what happened to the patient, what did bystanders say, what was the history of what happened when that patient passed out. A couple other things, I've never seen this, neurologists, trigeminal glossopharyngeal neuralgia, and then neurologic. So some TIAs or strokes, migraine, again, very rare, can cause you to pass out. Now, the heart conditions include things such as obstruction to flow, and what this means is the heart is a very dynamic organ. I'm not a cardiologist, but we work with cardiologists very closely. The heart's main output is called the aorta. So the aortic knob comes out of the heart. That's the main pumping vessel going to parts of the brain and the body. And sometimes you can get narrowing of that outflow, and it's called outflow obstruction. So, and here's a couple of causes, either valve problem, you have very narrow valves, the aortic and mitral valve. Myxoma is a tumor that is in the smaller chamber of the heart. And then some other valves and some clots to the lungs and blood pressure, the pressure that's elevated in the lungs, and then actually having a heart attack and dissection. So these are the more common causes, very serious causes of syncope. Some of these cases have to go to the operating room to get dissections fixed and things like that by the surgeon, either a cardiothoracic surgeon or a vascular surgeon. Some of the other causes are arrhythmias. Now these arrhythmias are more common. So you can have what's called tachyarrhythmias, means your heart is pumping fast for some reason. The heart rate is regulated by, again, I'll tell you, that vagus nerve that goes to the heart, and when that's stimulated, it slows the heart down. But the heart has its own electrical system that keeps everything pumping like it should and coordinated. So you can get tachyarrhythmias, the heart's going very fast and you pass out, or your heart goes very slow. This shows you the causes. So they did a workup at the Mayo Clinic. And it shows you over 2 years, looked at about 1,000 patients, looking at what were the causes of syncope. This is the group less than 65 and over 65. So you can see the majority of them were this vasovagal cause that I mentioned. A few of them, and this is actually darker than this. A few of these are cardiogenic, and some of the other, and look at this, 17% and 18% are undetermined, don't know the cause, and this is pretty common. We want to know. The doctor, the neurologist, cardiologist wants to know the cause, but sometimes we don't, and this could be up to 20% of the time we don't know. And then there's the congenital heart problems that are discovered when someone passes out. Much more common in the young than in the elderly. Okay, so I'm going to shift gears.
Is it more common in the young, you said?
What's that?
Is it more common in young people?
It's seen more picked up in very young than sometimes picked up in older populations, so there's a gap. Yeah, but the congenital heart problems usually picked up early, but not always. Sure. Let's talk about some cases. So these are real cases. 82-year-old man was found unresponsive at home by his son. EMS was called. They found the patient with a blood pressure of 160 over 82, pulse is 120. So his pulse is going very fast. A pulse should be less than 100, and the normal pulse is like 60 or 70 or 80. Patient has a history of high blood pressure and seizures. He was on some blood pressure medication and seizure medication. EMS found the patient several seconds of shaking activity, but no loss of urinary, or had no urinary incontinence or tongue biting. And again, as I mentioned, a lot of people think when someone passes out, it's a seizure, but everybody shakes for a few seconds when they pass out, whether it's a seizure or not, and most of the time it's not. So this patient came to the emergency room. They found he actually fell. He actually caused some trauma. He had a facial contusion. He was unable to move the left wrist. He had a fracture, in fact, that was seen on x-ray. His EKG showed a sinus rhythm, but actually it was going in and out of fast to sinus. And he had a few beats of what these are preventricular contractions, and possibly an old heart attack on that. So the question of what are the next steps in the workup? Well, he got an ECG and he was put on telemetry. So telemetry is a continuous monitoring of what your heart is doing. So it's read by a cardiologist just to see if, at 2 a.m. you're going in and out of the rhythm and no one has actually picked up on it. Got a head CT. And in fact, he was found in this rapid atrial fibrillation rhythm. So he came in, go back, sorry. He was rapid, but then later it looked like his heart rate. So he's going in and out of this rapid rate called atrial fibrillation. And that was the cause of his passing out. So his heart was going, it's irregular and it's rapid, so not getting the blood up to the brain. Head CT was normal, in fact, in this patient. And the treatment, he had a pacemaker placed. And because of the atrial fibrillation, and I just want to make this point, as my specialty is in stroke, if you have atrial fibrillation, the treatment for that, if you can tolerate it, is anticoagulation. That prevents clots from that heart going up to the brain. So he was put on anticoagulation to prevent a stroke and did fairly well. The workup for syncope also includes certain labs. So you want to make sure the glucose, you check a blood sugar. Is the blood sugar low? If it's low, that can also cause you to have that event. We do a complete blood cell count. Are you anemic? Is there an infection going on? We check the heart, we look at kidney function, and then sometimes a bladder infection will make you pass out. And sometimes a bladder infection can get into the blood, and it's called urosepsis, and people drop their blood pressure. The natural reaction of the body is you get an infection in the bloodstreams that drop the blood pressure, and sometimes that can lead to syncope. We do imaging. So we look at chest x-ray to rule out a pneumonia, head CT to make sure it's not a stroke or a hemorrhage, CT of the chest and abdomen to look for aortic dissection, and a CT of the chest to see if you've thrown clots to the lungs. And also we get an echo to look for, again, congenital or problems with the heart as a cause. And in the cardiac monitoring is the EKG, and sometimes a more prolonged recording once the patient's out of the hospital. Tilt table test is trying to induce a drop of blood pressure mechanically. So literally a patient's put on a table and the table's flat, and then they prop them right up quickly. So they want to see, does that blood pressure drop really fast? Is that the cause of your syncope? And then a stress test if it's needed. Let's talk about another case. So 72-year-old man had hypertension, elevated cholesterol, had a heart attack in 2010, and his doctor recently started him on new blood pressure medication, and he had just taken it for 2 days before this event. He came to emergency with sudden onset of dizziness, followed by loss of consciousness for just a few minutes. Again, his wife noticed shaking of his limbs while he was down. EMS was called. He woke within less than 1 minute, with less than 1 minute of confusion, and immediately returned to his usual self. What's going on? What happened to me? Did I really pass out? Denied any complaints. I'm sorry. He had nothing to suggest that this was a seizure, but his vital signs on the admission, his blood pressure was low, his heart rate was fast, and it was irregular. 12-lead EKG telemetry showed no arrhythmias despite the suggestion that it was fast and there was irregular, which might have been a suggestion that this was atrial fibrillation. And the head CT was negative, did not show a stroke, but blood pressure was low. So the diagnosis was syncope due to low blood pressure due to the medication. And it's hard for us as doctors to know which patients are going to be sensitive to these medication. I wish it was more of a clear science, but I tell all the patients when I'm starting new medication, these are the side effects. It may not happen to you, but you need to know these are the side effects of certain medication. And certainly, starting a blood pressure medication, your blood pressure can drop. And so the treatment was, guess what? Stop the medication. No further events. The treatment is usually based on defining the cause. Is it heart-related? Is it not heart-related? Are you dehydrated? Do you need to drink more water? It's not, a lot of it's not rocket science, I'm sorry to say, but it is sort of basic and very pragmatic. Rule out heart cause. If there's a heart cause, then that needs to be treated. Rule out neurological cause, as I mentioned, is very rare. If it's a seizure, then you'd be put on seizure medication. Remove the offending agents if it's a medication. Keep well hydrated, and then sometimes we can use some agents that increase the volume of blood. If someone really has a hard time and their blood pressure drops every time they stand up, and it drops a lot, and some patients can be very refractory. They almost pass out every time they stand up. So an extreme case of this, we put them on one of these medications, fludrocortisone, a mitogen, to help kind of boost the volume of the blood and kind of keep that from happening. So when you stand up, your blood pressure doesn't drop. TED stockings are useful. And in some cases, the doctor says you should decrease your salt intake because blah, blah, blah. In some cases, we say, actually, we want you to add salt to your food. We want to get that volume of blood up. And so in some cases, we'll recommend, salt the food as you like. Let's talk about a third case. A 50-year-old woman, history of hypertension, GERD, shopping in a mall in the afternoon when she suddenly passed out. She was caught by a witness as she fell over. She did not hit her head, fortunately. Within a minute, she was awake and alert, had no neurological complaints, but had not eaten all day, and it was hot outside. 12-lead EKG, telemetry, normal sinus rhythm, occasional sinus tachycardia, and this is kind of expected in a young person. A lot of young people, the heart rate tends to be a little bit more labile, and particularly in the higher end, so a young person can get a little tachycardic, which we think is any heart rate above 100. And so it may not be all that abnormal in a younger person, but hers was, was a sinus rhythm and occasionally went real fast. Head CT was normal, workup otherwise negative, and we diagnosed her with this vasovagal syncope. So, eat during the day, drink fluids. If it's hot outside, go inside. These are very pragmatic recommendations, but they can really be effective. And this woman did that, avoided going all day without eating, and never had a recurrence. Stay hydrated, nourished. Case number 4, a little more complicated. This comes down to, this is a neurological case. 76-year-old man, Parkinson's disease, on medication, walking to his doctor's office when he lost consciousness. Did not hit his head, but appeared groggy for about 5 to 10 minutes after the event. And like I mentioned, this is a little red flag for us, that there's something else going on here besides just dropping, besides a vasovagal event. EMS was called. His blood pressure was also a little low on arrival. Heart rate was okay. And he was taken to the emergency room. He had ECG showed that his heart rate was just running a little bit low. What's called bradycardic means the heart rate's a little bit slow. But it turned out when we went back and looked at the records, he'd been slow for years, so this was not abnormal for him. His heart rate's about 50 to 55, maybe 60, and the normal range for heart rate is between 60 and 100. So his ran a little bit low, but that was normal for him. So we sort of wrote that off as that not being a problem. Telemetry showed sinus rhythm, no evidence of heart disease. His cardiac enzymes were negative. There was no heart disease involved. But every time he stood up, his blood pressure dropped, and we do what's called orthostatics. So we actually, in the clinic, will test somebody lying flat, sitting, and standing. We look at blood pressure and heart rate. And if you're truly orthostatic, your blood pressure drops a lot when you stand up, and your heart rate goes up. So with those changes, we found him that he was very orthostatic on our testing. And so it turns out what's common with Parkinson's disease patients is they can develop what's called autonomic failure or autonomic problems. And that means that mechanism that I mentioned at the beginning of getting that blood back up to the brain when you stand up is not working well at all in Parkinson's patients. So they can develop a lot of these orthostatic changes, and so it can be a problem with this patient. So we treated him, we asked him to increase his salt intake, to wear tent stockings, compression stockings in the lower extremities, stay well hydrated, and slowly get out of a recumbent position before walking. Take your time. Don't get up fast. Take your time. Slow. When you get up slow. Dizziness goes away. You're ready to go. This can be a pretty severe issue with Parkinson's patients, particularly as the disease progresses. So you have to be pretty aggressive and do what you can to help these patients. When can you tell that it's a seizure or not a seizure if you pass out? And I've been talking about this sort of all along. There's a separate study looking at if you have tongue biting on presentation. So when EMS finds you, you've bitten your tongue, it's pretty strongly suggestive of a seizure. You can see in this study 99%. But it did not exclude the possibility of seizures. 24% did not bite their tongue but had seizures. So it's not often an issue, but spell with syncope versus seizure has to be ruled out. And this is what this study looked at. Now, I put, if it's a seizure, frothing at the mouth, I'm not sure what that means as a neurologist. I know people say it. Was the patient frothing at the mouth? I said, I don't know what that means. What do you mean frothing at the mouth? But usually with a seizure, the mouth is moving and you're shaking. But they put this in their definition. But clearly if you bite your tongue, it's more likely a seizure if you're disoriented. So in my neurology note, I'll put tongue biting, loss of bladder bowel function, and they were postictal. Postictal is a term meaning they were confused for a period of time after they passed out. They didn't wake right back up and go, hey, what's going on? They didn't wake up, they were confused, disoriented, and this can go on 15, 20, 25 minutes. It's prolonged, it's called a postictal state, and that is very suggestive of seizure if a patient is younger than 45 and the loss of consciousness was over 5 minutes. Again, most of the syncope we talked about is a few minutes. Boom, on the ground, you wake up, you're awake. It's not a seizure when you have sweating prior to an episode. Sweating is sort of an autonomic process. That means the body's sensing something's wrong. Your blood pressure's dropping, you're about to pass out, you may sweat, you may feel tunnel vision. This is nausea prior to episode, oriented immediately after the event, and you're older than 45. So it's pretty good. I think the tongue biting and disorientation are really red flags for us that, yeah, in fact, this is a seizure. It tends to happen in people that have a history of seizure or on medications for seizure. So, but some what we call de novo patients come in and diagnosed with a seizure that never had one before because they passed out. Okay, a last case, 68-year-old man, high blood pressure, diabetes, coronary artery disease, had a heart attack, presents with a sudden onset of spinning in the room. He comes in and says, Doc, I can't stand. Everything is spinning around. I literally could not stand. He was in the bed holding still because every time he moved, things would start spinning, and he got sick, and so on. EMS was called, vital signs were normal. Neurological exam was normal, except that the family noted that his eyes were jiggling. They noted his eyes were moving around, they're jiggling around. And this is an interesting finding. This is actually a pretty astute finding by family members to actually look at the eyes and to see they're jiggling around. Came to the emergency room, and on their exam, what the jiggling was rotary beating nystagmus to the right in all directions of gaze. And what this means is the eyes, nystagmus is the term meaning the eyes are twitching to one side. Usually it's to one side. And what we can determine as a neurologist, there's two things that cause the nystagmus. One is an inner ear problem that causes vertigo. The other is a stroke. The nystagmus with the inner ear problem has a sort of rotary component, kind of rotates off to the side and goes just to one side. If someone has a stroke, but that's only in someone who, back up, someone who has vertigo but not a stroke, they have to look to one side for that beating to occur. Someone with a stroke looking straight ahead, the eyes are literally jiggling. And that wasn't exactly what the family described. They said, yeah, we noticed every time you look to the right, we'd see this movement of the eyes. So pretty astute. And again, that's a benign finding. So finding rotary beating nystagmus when it goes to one side is a benign finding. Otherwise, non-focal neurological exam. Head CT was negative. And so he had this term, benign paroxysmal positional vertigo. Fancy term. What that means is, with position, it elicits this vertigo and spinning. And this is a benign condition, but as I mentioned, sort of at the beginning, can be disabling. And so some people, when they get in a certain position, it happens, they have to sit down, they feel nauseated, and they can't actually move. And the treatment is self-limited fluid intake. Meclizine is a medication you can take to help that. And again, I tell my my patients that are tech savvy and go on the internet is to go on YouTube, and there's this maneuver called Epley maneuver. And what it does is it repositions the cause in the inner ear, and you do the maneuver, and you can actually get rid of vertigo, and sometimes it can be very effective.
How do you spell that?
What's that?
How do you spell that?
E-P-L-E-Y, Epley. And YouTube has got great images and videos of this, and it's you position the patient. And I'm just going to back up, and I'm going to get into a little detail. So I'll tell you a little bit of detail about this benign positional vertigo. What the theory is in the inner ear, there's an apparatus that determines where you are in space. And this apparatus has a base to it, and it has these three called semicircular canals. And they're tiny little canals that are oriented in a way that if you're upright, you know you're upright. If you're upside down, you know you're upside down. Very fine-tuned device, tiny made of bones that sits in the inner ear. As we age, as everybody ages, and this could happen even at a young age, sometimes little pieces inside those little circles of bone break off. And they float around, and they stimulate the base abnormally. And when they float down to the base, the base has these fine hair cells. And they stimulate the hair cells, and it tricks the brain that you're actually spinning, so you start spinning. So that's the sort of detailed explanation. So that Epley maneuver is trying to reposition those particles floating away from that base, and it can be very effective. You can reposition these particles where they don't stimulate the base, and the vertigo actually can go away. For this patient, if the symptoms lasted longer than a week, we may actually be wrong, and this actually may be a viral labyrinthitis. Same process in the inner ear, but it's a viral infection, and that usually takes longer to recover from. That could take 7 to 10 days for someone to recover. The benign positional vertigo usually is a couple of days, someone's doing okay, and we discharge them. But both are self-limited and benign processes. Let's finish up with dizziness. So dizziness is lightheadedness, unsteadiness, again, feeling of floating or swimming. When you call a doctor, if the dizziness is associated with a headache, high fever, neck ache, these are all signs and associated symptoms of problems. Blurred vision could mean a stroke. Difficulty speaking could be a stroke. Numbness or tingling or droopiness of an eye or mouth. Again, these are all stroke-like symptoms. When in fact, you can get dizzy. And very rarely you could pass out from having a stroke. Certainly chest pain suggests heart problems. Vomiting suggests you could have a bleed in the brain. And so these are some more serious associated symptoms when you should call a doctor, and actually you should come to the emergency room if you have dizziness and you have any of these associated signs or symptoms. Causes of dizziness, low blood sugar, labyrinthitis, that's an infection of the inner ear that we just mentioned, low blood pressure, orthostatic hypotension, high blood pressure. You could have blood pressure through the roof and get dizzy. Very rare, but it has to be extremely high. Dehydration, medications, cold or the flu, panic disorder, motion sickness, severe anemia, your blood counts are very low, there's a problem, you're bleeding somewhere, and you can get dizzy, or a heart attack, or a stroke. So it's a long list, and again, if you have any of the associated symptoms or dizziness comes on all of a sudden, you should go see a doctor, come into the emergency room. And I think that's all I have. No, I've got treatment. For dizziness is underlying condition. We talked about this benign positional vertigo. Avoid caffeine, alcohol, tobacco. That makes dizziness worse. See if there's medication, hydration. We've talked about these other things. And In some cases, I'm very fortunate here in Queens and the Queens areas, there's a very good, what's called a vestibular rehab facility that's associated with an orthopedic group. And they actually have a machine. So again, this is for vertigo. You have spinning that's incapacitating, the benign vertigo. They have a machine that they put you on that actually stimulates motion. And it tricks the brain and desensitizes the brain to vertigo. And it can be very effective. And I've actually sent 3 patients there already, and they've gotten pretty good relief. And sometimes, I mentioned, vertigo can be disabling. So this is my family. I don't know if you can see. This is my wife, Kathleen, and she's a surgeon. This is my daughter, who's a figure skater. And I have to brag because I'm a proud dad. But my daughter was in Dallas skating with Todd Eldridge, who was an Olympiad. And she's taking lessons from Todd. And she was skating recently in Lake Placid at one of the competitions and did well. And here she is with her medal. So thank you very much.